this week on the BackTable Podcast.
I'm just very excited to be in a field that is so rapidly evolving. It's for the first time that this kind of disease that we treat also encounters a lot of interest from industry, from pharmaceutical industry. That means that there's a lot of advocacy, a lot of money just frankly coming into the specialty. And I think that's an opportunity for us to ask the right questions, do the right trials, get them funded and get them done. And I think that's a once in a lifetime opportunity where if we don't lead, we're going to be followers. And I think it's going to be up to us to generate the high level data that we need to maintain our membership in the multidisciplinary care team.
Today, we're going to be talking about HCC, hepatocellular carcinoma. Specifically, the topic is the role of TACE and immunotherapy as a treatment strategy for these patients. As some of our listeners may know, we have really tried to cover HCC from A to Z with BackTable Tumor Board. To add to this catalog, we're going to add this episode discussing TACE and how that fits into the treatment algorithms. To help us with this topic today, we got two good docs here. We have Dr. Richard Finn, medical oncologist, UCLA. Thank you, Richard, for coming on. And Dr. Julius Chapiro, IR at Yale. Guys, welcome to the show.
Thanks. Thank you for having me.
Julius, because you're IR, we actually default to the oncologist here. Richard, do you want to give a quick intro about just yourself and what your practice looks like right now?
Yeah, hi, Richard Finn. I'm a medical oncologist at UCLA. I've been here for some time, really with an interest in drug development and lab-based biomarker predictors. And in that context, I've been involved in the breast cancer space a little bit, and most of my time now is in the hepatobiliary space, working with a very strong multidisciplinary program here at UCLA, based in liver transplant, but supported by interventional radiology, medical oncology, hepatology. I've been very blessed to be involved in some very important clinical trials in liver cancer.
Very nice, Richard. Welcome to the show. Thanks for coming on. Julius, listener of BackTable, but also give us a rundown of your practice and kind of where you're at now at Yale.
Sure. I'm Julius Chapiro. I'm an interventional radiologist at Yale. I'm also a principal investigator in one of the few interventional oncology research labs across different institutions. And I'm also very blessed to work in a very science-based multidisciplinary team of physicians and scientists. Actually, one of the very few nationally NIH-supported liver centers. Yale is sort of a place where I've been for a while, and I'm really proud to be here. I mean, a floor here is named after Gerard Klatskin, right? So very famous liver doctor. So we have fantastic medical oncologists, hepatologists, liver transplant surgeons, and radiation oncologists, and pretty much amazing colleagues in IR from whom I'm learning every single day, and very strong academic practice. And, my work for the last, 12 years has been mostly in HCC, biomarker development, AI, and image-guided therapies.
All right. Very nice. Julius, also, thank you for coming on the show. Richard and Julius, you guys may or may not know, but we've covered a lot of this stuff in the topic, but I want to at least give you guys just both open mic as the kind of set the table about HCC and just introduce the topic to the audience, and then we'll jump into the real meat and potatoes of it. Richard, do you want to start?
Yeah, sure. I mean, from the oncology standpoint, liver cancer is fairly unique. We know what causes it. Chronic liver disease in 90% of patients, where most cancers we don't. And I sometimes make parallels to lung cancer because it's a malignancy that's occurring in a very critical organ, right? And usually that organ is sick. In the context of lung cancer, it's COPD and lung disease. In the setting of liver cancer, it's cirrhosis. And how we approach patients is really not only dictated by the tumor characteristics, but the characteristics of the patient and their underlying physiology. Very different to have a 2-centimeter tumor in someone who is well compensated, Child-Pugh A, no portal hypertension, as compared to someone with a 2-centimeter tumor with a bilirubin of 8, renal failure, and bedbound, right? I mean, two very different scenarios, and by the TNM staging system, they're the same, right? Stage 1 tumor. But obviously their prognosis is very different, and that's where a system like TNM fails our patients with liver cancer, because it ignores this fundamental underlying risk of outcome and death, which is their liver function. And so that is why I think largely the Barcelona system has been adopted. There's many very good staging systems globally. In the modern age, most of them try to capture the liver function, as well as tumor characteristics. And it has served to be prognostic for its various stages. And it really has been the backbone for clinical drug development and clinical trials. So we can all speak the same language across disciplines and across regions. I could go on for an hour, but I'll let Julius chime in as well.
All right, Julius.
Yeah, definitely second all these comments from Master. I will say, from a radiological perspective, liver cancer is a bit unique in that it's one of the very few cancers that can actually be diagnosed in non-invasive fashion. And in my view, this comes both as a blessing as well as a curse, because as a scientist, I always want tissue and I want to sort of understand biology of a tumor, and liver cancer is extremely heterogeneous because it's very poorly understood in terms of its molecular bioprofile, mutational map, and so because it has been diagnosed using LIRADs in these patients, and because we were blessed to have amazing diagnostic tools like the MRI and like triphasic CT, that in many of these cancers gives us the diagnosis just by imaging features. At the same time, we've, I think, for a long time missed an opportunity to understand these cancers and to map them out with retrospective and sometimes even prospective data from a biological and pathological perspective. And so IR has, once again, a very, very important role here, not only from the side of local regional therapies, where, of course, we're represented, but also from obtaining samples, I think. And I think this conversation is picking up a lot right now in light of the so many upcoming drugs and trials.
Mm-hmm. Well said. All right, so I just want to talk about some boring stuff first, but feel like kind of a little bit necessary. And Richard, we'll kick it over to you. I kind of want to know, like in the UCLC system, particularly with your practice, what are the referral patterns for HCC? Like how do they get plugged in with oncology?
Yeah, that's a very good question. And look, I'm at a large tertiary center, and I've been here a while. And, I'd say historically, and probably still, the backbone of a successful program is going to be driven by transplant. And that puts you on the map, really, because that is the backbone of cure. And when I say transplant, often that's associated with hepatobiliary surgery. But the reality is most patients are not going to be surgical candidates. At a large health system, we control a lot of patients because they're part of UCLA Health, and they get referred in either to hepatology with a liver mass. Some of them will be referred from hepatology to then the liver cancer center, and I'm part of that. At the same time they see me, they might see the surgeon, or maybe they'll just see me first. And I'll let Julius speak to this, and I'm speaking a little bit for my IR colleagues at UCLA. I mean, they have a big presence, and they probably get direct referrals themselves from outside UCLA and within. But I think most of the referral pattern comes through internal medicine in some way, whether hepatology or directly to oncology. Surgery will see patients, and unless they're directly a resection candidate, which few are in the US because our patients generally have some degree of portal hypertension from Hep C or metabolic liver disease, NASH, MASH, unlike the East where hepatitis B dominates, and those patients are not as cirrhotic and they do have more resections. But, patients will come in, they can't get a transplant right away. And as part of their evaluation, they see medical oncology or the liver cancer program to help manage them while they're waiting for transplant, right? And also weigh in on their candidacy. In my practice, are involved with patients of all stages. That's different than in the community where someone with liver cancer might just see the oncologist when they have metastatic disease, or they're not part of a very active multidisciplinary program. Things are fractured a little bit more in the community, and maybe the hepatologist might send someone to IR, and when IR is done, send them back to hepatology or oncology, and it's a little less organized. But at our center, I'm seeing patients, direct referrals to me because I'm known in the community, in the cancer community, direct referrals to hepatology, and then to me, or even from surgery.
Is it a fair statement that even if patients are referred directly to you, like outside of the liver program, is it a multidisciplinary approach where if you see somebody, then you're like, well, we really need to touch base with hepatology or something like this, Richard?
Yeah, these are good questions because like the multidisciplinary program is just 1/2 day for me, right? Because it's hard to have that 5 days a week, right? And so I do see patients on other days on some offsite, main campus is in Westwood. I have a very busy oncology practice in Santa Monica, our other part of our health system. So certainly for patients that are not advanced, I will bring them to the tumor board. So I see plenty of patients that are intermediate, liver confined, and I'll bring them to the tumor board to get them tied in with a plan on how we will manage them. I focus a lot on research and obviously try to prioritize patients for research studies. But I'll see patients who I think are resectable, right? They come in for a second opinion and someone recommended medical treatment. I'm all, slow down. You might be resectable or transplant candidate. And that's very important for transplant, especially because the guidelines are changing so frequently, as far as size criteria, downstaging criteria. And there's plenty of data that has shown that patients managed at a multidisciplinary program tend to do better. Certainly for patients that I don't really think are appropriate for anything other than medical treatment, I don't feel obligated to bring to the tumor board. But at the same time, some patients come back, meaning they're large infiltrative tumors, they've had a great response to treatment, and maybe now they are candidates for a more definitive approach, especially in the modern age of the drugs we have with immunotherapy. We see significant responses, right? So, I have patients who have been unresectable that then get atezo-bev and continue to shrink and eventually, nadir, and will go on to receive a surgical procedure or definitive, maybe radiology procedure. So eventually, I think many patients do go to the tumor board, certainly all of the early and intermediate, and increasingly some of the advanced.
Julius, same question, kind of like referral patterns and how your practice looks as far as where you fit. I'm sure you guys have a multidisciplinary approach also, but kind of paint a picture of what y'all's practice looks like.
Yeah, I work as part of the liver cancer program here at Yale right now under the leadership of hepatology. But I would say that it's a very fairly evenly distributed practice in terms of how decisions are made. Obviously, we see a variety of different referral patterns. So some of the patients that I see and find are just patients who really appear through the emergency room and are incidentally found to have tumors or admitted for decompensation of their cirrhosis. And then we got a referral for biopsy. And biopsy is an important tool for us to just diagnose HCC. And then sometimes we are the first to see these patients in a health system. And then I tend to, I would say almost always to bring the patients to the multidisciplinary tumor board, simply because I feel as though while the maybe BCLCs of the past and sort of the treatment patterns of the past would allow, in certain cases, an IR alone decision, now in a day and age where we have combination therapies, even if I think that a patient is a great candidate for TACE, I do want our medical oncologist to chime in. And I do want our hepatologist to tell me whether they believe this patient is a good candidate for local regional therapy or not, and whether from their perspective this patient is compensated enough to tolerate it. And, and I do think I want to second what was said there about transplant and sometimes downstaging or bridging. I think trying to bring cure to every single patient that we see is a fundamental mission, no matter what specialty we have. And if there is someone who can be bridged or downstaged, I do want our transplant program to know about this. So I think multidisciplinary care is really important.
Okay, well said. Just quick question, a quick aside. Richard, how many of your patients with suspected HCC?
Yeah, it is still a minority, I think, because, there's suspected and diagnostic, right? And for someone who is clearly cirrhotic with a LIRADS5 lesion, hypervascular with washout in the right clinical setting, generally we do not biopsy them. Now, with that being said, for patients who go for ablation, the radiologists do tend to do a biopsy at the time of ablation, just by practice pattern. There are patients in the context of research studies now which do want tissue for either biomarkers or confirmation of diagnosis. But I think the majority are not being biopsied outside of those scenarios. And, Julius brings up an excellent point in many ways, how much of liver cancer progress has been delayed by the lack of tissue available. And I think there's two ways that we think about that. One is to understand tumor biology and identify new targets or approaches for treatment. The other part of that, which is increasingly important, is linking, some biomarker in a biopsy to a therapeutic, right? A predictive marker, right? Which we lack dramatically in liver cancer. I mean, the only drug that is associated with a predictive marker of benefit is AFP, and that's for ramucirumab in the second-line setting. But no other drugs have really been developed with a companion diagnostic. That's the term we use in medical oncology. Something that you need to test, whether positive or negative, tells you how to treat patients. And that is really an important part of our mission in cancer medicine and getting the right drug to the right patients, especially now that we have several choices that all have positive data. How do we decide which is best for the patient in front of us? And that's an ongoing translational effort.
Julius, I saw you nodding your head for part of this. Anything to add as far as from the biopsy question?
Yeah, well, I mean, obviously, as a scientist who's trying to develop biomarkers and thinking about molecular imaging or, even machine learning approaches and how to identify what kind of tumor we're dealing with and whether or not this is sort of like an immunologically hot disease or whether or not this even is going to be predictive for a good response to immunotherapy or which particular drug. I think, I understand when someone tells me that biopsy is going to be risky or, there is a risk of seeding, which I think is more or less theoretical. And even some IRs will say, like, if you biopsy a tumor and then you have to do an embolization, then you're going to create possibly a shunt or a fistula. I just feel as though, we've probably missed an opportunity to investigate this cancer better. I think I'm discovering and understanding the system more with the years that I do research on these patients. I think that the resected samples are a great treasure for us to really better understand. Although most of these patients don't undergo immunotherapy before, but some now have. And I think that those samples are going to be more and more important for us to understand really what is going on in these tumors.
Just for the discussion, because like you, I have no fear that biopsy is dangerous in these patients. I know experienced IRs can do this. There's no real risk of seeding. You burn the tract, you go through a cannula. I guess the issue is, LIRADS is, when you have a LIRADS 5 lesion in the right patient, it's pretty diagnostic, right? That's been the challenge to overcome for us, I think, right? You've done yourselves very good at radiology, better imaging, better protocols. And then it's like, well, now we don't need to do it because we need tissue. But I agree, biopsies are really important for us to move forward.
Just quick aside. So now I want to ask Julius. I'm going to hand the mic over to him for a little bit. Julius, before I ask a lot of the questions about TACE and how that goes to immunotherapy, we just take a minute and explain TACE and how you do the procedure and just kind of lay that out for us. Just a little gearhead talk.
Well, TACE, Transarterial Chemoembolization, is actually a very old procedure. It's been designed in Japan and then, basically tested in patients mostly with what we today would describe as intermediate stage disease over the course of, more than 30 years, well over 30 years actually now. And the initial protocols have been done with Lipiodol, which is basically an ethiodized oil, which functions as some people call it a triple threat drug carrier, embolic agent, as well as imaging biomarker. And, that mixture, that is usually mixed in a emulsion with historically 3 drugs have been used. And this is usually doxorubicin, cisplatin, and mitomycin. Cisplatin was gone for a little while in powder form from the market. And, a lot of people have used 1 or 2 drugs. Standardization of the chemoembolic mix was a problem, but I think it was addressed fairly well over the past 15 to 20 years. And I think when we do conventional chemoembolization or chemoembolization with Lipiodol, we do it in a fairly standardized fashion. And then after the administration of the mix, we close the back door of the feeding artery usually with particulate embolics or gel foam. It has been demonstrated that particles are better and produce more durable responses than gel foam, which is a temporary embolic. And then, of course, there has been interest in more, some people say, reproducible form of TACE, and that was the drug-eluting beads TACE, which was introduced about 15 years ago and tested predominantly to avoid systemic spread of the chemotherapy that is being introduced and also limit the side effects and be in a more targeted fashion. And while it has been demonstrated that it's able to reduce the sort of systemic side effects and confine the chemotherapy more to the liver and to the targets, the real outcome metrics, sort of the overall survival, tumor response rates, really have not been much different from conventional chemoembolization. And because the majority of the world from all intraarterial therapies is still using chemoembolization, it has been also the therapy of choice for most of the randomized controlled trials and high-level data. It is still the only high-level intraarterial therapy with level 1A evidence in HCC, and has been that for a while. Predominantly, I think, driven by Asia and the availability of the therapy across the board. That's what I will say about CTACE as a brief introduction, I guess, or CTACE and DEBTACE.
Can I just dig in a little bit, though? In your practice, are you using DEBs or Lipiodol?
Except for the VA, where Lipiodol is a non-formulary, we're using almost exclusively Lipiodol in our institution.
What's your drug cocktail?
Cisplatin has been really irregularly available, so we're using mostly a double drug cocktail. Unfortunately, some of my colleagues prefer to change it from time to time. Some people had mixed it, with beads when they administer the Lipiodol. In my personal experience and the way how I do it, particularly because we like standardization, I feel that a standardized approach, highly standardized way how you mix it, what you use, what kind of drugs you use is extremely important. And because doxorubicin is the one thing that is always available, I mostly use a single drug cocktail with Lipiodol. Other people will say, why not using 2 or 3? It's just because the remainder of the drugs are not consistently available. And I believe that unless you do something the same way all over again, it's probably your results are not really sustainably comparable. And I would say, you have to have a rules-based practice, I would say.
So, Richard, I'd actually like to bring you in and just ask, do you have any commentary on the TACE procedure or with your interventional radiology colleagues? Because I can just say from personal experience, that is sometimes a knock against interventional radiology from our medical or surgical colleagues, that they, depending on which interventionalist you send it to, you may be getting a TACE, but the TACE can differ between practitioners.
Yeah. I've been around a while. I finished my training in 2003 and joined the liver program even as a fellow. And I've seen the evolution. I mean, I remember the Precision 5 study, and that was a big discussion in the space. And, I grew up in a center that was very much CTACE based and have a lot of respect for my colleagues. I mean, at that time, Tony Gomes was probably our main vascular person, and I worked very closely with Dave Liu and Steve Raymond, who are more ablation people. And as the program has grown, more people have come into the space. Justin McWilliams, and more recently in the past few years, Sid Padilla, who has really brought Y90 to UCLA. And to me, the most important part of the procedure was the embolic part, to be honest. And I know people have looked at TAE versus TACE, and there's various data. The exact drugs, to me, there's nothing magical about doxorubicin or cisplatin or whatever, minomycin. These are all cytotoxics, right? They're poisons. And certainly, I think when you're injecting a poison right into the tumor, as long as it's safe, it probably doesn't matter what you put in, because it's different than putting something in the vein that goes everywhere. And even in that context, a lot of times putting combinations together of cytotoxics only improves toxicity and not necessarily outcomes. And that is why, things like response, which you can always typically improve with combining things, cytotoxics don't always lead to improvements in survival outcomes. So given it's different here, it's going in the vasculature directly. I suspect that the embolic part, because liver cancer, you see that on your angiograms, it's a very vascular tumor. It's unique in that way. And a lot of our drugs target the vascular nature of liver cancer. So I do think the embolic part of the TACE is important. I wouldn't stand and tell an interventional radiologist how to do a procedure or what to do during that procedure. I think they do it very well and they know best. But I think what you're referring to also is, levels of evidence and data-driven studies, right? And I do have an issue with the field. I mean, some people say, look, you don't need a clinical trial to know a parachute works, right?
That's a good line.
Or, people say, look, liver transplant, the initial study by Mazzaferro in the New England Journal was like 40 patients or less, and liver transplant became the standard. There's never been a randomized controlled study for a liver transplant. With that being said, there have been randomized studies going back to 2000 and 2002 from the Barcelona group and in Hong Kong, studies of TACE versus placebo, right? These were done, and they showed that TACE was better than placebo to improve survival in a randomized controlled study. Seems after that, though, a lot of these studies have fallen off, these high-level evidence studies. To that point, Precision 5. From what I remember, that was a randomized study of DEB-TACE versus C-TACE, right? And, there were some toxicity issues that Julius referred to, but really no benefit in survival outcomes, I don't think, and response rates, I think, were pretty much the same. And since then, a lot of the radiology literature is retrospective, single institution, multi-institution retrospective, and there's value to that. But when you're talking about clinical practice versus guideline development, that's where you need higher level of evidence for the guidelines. I think the issue that drives a lot of this is that approvals in interventional radiology, things are devices. Even beads are a device, from what I understand, right? And the level required from the regulators to get these things approved is not the same as for a drug. You have a negative study with, Brivinib, a drug that was being developed by BMS in combination with TACE, in combination frontline, second line. The drug failed. It's not available. It's gone, right? The TACE study was stopped early because the frontline study was negative, so BMS stopped development. So in the TACE study, stopped early, it's not approved, right? So without, I think, that requirement, it's going to be hard to change the practice. I mean, I know people are academic and they want to do that and generate that data, but it has to be driven either by the government and the NIH to fund these type of studies, or industry should have to do it in order to market something.
Julius, not changing topic, staying on this topic, but redirecting a little bit. Patients who refer to you, you have a set of tools in your toolbox between ablation, radioembolization, TACE. How do you think about patients to then slot them into whatever procedure you'd like to perform? Or, maybe like they're not a candidate for any of the procedures that you do, but
I use all of the three that you mentioned. And my first question is always, can I cure a patient, right? And what would I need to do to provide a cure or to achieve a complete response at the very least? That's my first question that drives the entire conversation. And does that mean, would I use one of these therapies? Would I use a combination? Would I ask a colleague from, a different specialty to help me out to achieve a, complete tumor response in this patient? And that's my first question. And then once I know that this patient is a candidate for local regional therapy, for example, not a candidate for surgical, resection or transplant even, then I would try to find a combination of tools that I believe are safe for the anatomy. And so obviously, a lot of things are in consideration here. So number one is, will the patient tolerate the procedure? And number two is, how can I do this procedure safely with taking as much of the tumor or all of the tumor out while damaging as little liver as possible. This is particularly important with patients who don't have preserved liver function or, have somewhat compromised liver function. And then I think that, tumor size obviously matters. The location of it matters. Structures at risk, next to the tumor matter. The pathway towards the tumor matters. And then the next question for me is, how does the tumor actually look? And I think that the phenotype of the tumor is extremely important. And experience just teaches you that there are some very bad looking tumors and there are some good looking tumors. And, this really round, peripherally, encapsulated appearing enhancing lesion with really washout that is far away from all the central structures. I mean, to be honest with you, you can taste it. You probably can do a red sag in it. And you can do a lot of things to it. You probably will achieve a complete response, right? In a patient who has this angry-looking infiltrative tumor with, unclear imaging features, may have needed a biopsy, looks heterogeneous, there it is very unlikely, that you'll achieve a complete response from the first shot unless the blood supply really allows for complete targeting of the entire segment and is safe. And so that's how I go about it. I think that I think that the first and most important question is, can you achieve a cure?
Okay. But to dig in a little bit more, so then let's take ablation aside, like chip shot ablations where you can get margins. It's in a safe area, not adjacent to any vascular structures. But I feel like at least, well, I'll let you speak to it, but there are tumors that have overlap between whether you want to treat with the yttrium or whether you want to treat with TACE. And then like what's creates the decision between which way you decide to go?
So I think that classically in historically portal vein thrombosis and the extension into the adjacent portal veins has been very important. I mean, as we all know by now, Y90 has been less embolic. And so in patients with compromised portal venous perfusion of the liver, you would probably gravitate towards Y90 rather than chemoembolization. I think, speaking about the choice between these two, I think that in a large majority of these patients, you can achieve complete response with chemoembolization. And the more important question for me sometimes is, can this patient tolerate multiple treatments and multiple procedures? And that's, the practical question is, will this patient be able to tolerate a mapping study and then coming back for Y90 delivery? Is there a shunt? How does this tumor look? And can I actually safely deliver a high dose of Y90? I mean, with the modern dosimetry, I think we understood that doing a Y90 without achieving a threshold dose necessary for complete path necrosis, you may not be in good hands. And so I think many of the patients that I see, they sometimes have just one shot at it. And then I bring them in for a chemoembolization, and I think that it's sometimes a lot more straightforward, just easier in terms of, the logistics of it. And then there are patients who just tell me outright in clinic, they don't want to have any symptoms that they want to feel. They want to have as little impact on their daily life as possible. And there sometimes I gravitate more towards Y90, where I don't think that they're going to tolerate a post-embo syndrome very well. And so those are the guides that I bring to the table when I think with a patient. But generally speaking, I personally tend to gravitate towards the evidence that we have. And when I believe that we're going to be combining this patient's local regional therapy with immunotherapy right now, frankly, there is no evidence for the combination of Y90 and immunotherapy, but there is pretty strong evidence in favor of TACE plus immunotherapy in 2 trials. And I think that when I believe we're going to be going for a combination, I just gravitate towards the data. I mean, once again, just to emphasize, our specialty and local regional therapies on liver cancer have suffered from the lack of data. And I think we just have to adhere to it, right? And there is pretty good damn data for TACE in this circle.
All right, Julius set it up perfectly. Richard, so my question to you, or you can kind of just riff off what Julius was saying, but whenever you have a patient who you're going to treat with immunotherapy, but you do want interventional radiology to get involved, or even maybe when you're not treating with immunotherapy, maybe when you involve interventional radiology, do you have an opinion? Do you have a strong opinion as to what happens with that patient as far as like whether they take them for an ablation, radioembolization, chemoembo?
Yeah, I mean, certainly, our institution, as many have gravitated towards Y90 over the past decade or 5 years, right? What strikes me is, you look at the legacy study, right, which I think was what the FDA used to give a little higher level of approval for Y90. I mean, the average tumor there was 2 centimeters or 2.5 centimeters, right? And even more, the majority of the tumors, I think, were under 3 centimeters. And often, to me, those patients would get an ablation, right? And some of those patients, I might just refer directly to my ablation colleagues, because to me, that's less invasive. It's very effective for these smaller tumors, unless there's a anatomical reason that that's not an option and they need a vascular approach. For the vascular cases, I usually don't tell, as I said before, I don't tell another specialty how to practice, right? If they feel that one approach is better than the other, then I would defer to them. I mean, I think Julius gave a very thoughtful discussion of how he approaches patients and the limitations to the various tools he has in his toolbox. But look, I've spoken at meetings, I debate, and it's not my debate per se to say TACE versus Y90, right? Studies that are quoted as saying one is better than the other are not very strong levels of evidence, right? I mean, there was the TRACE study, I think, which was one of the randomized studies. These are 30 patients per study, right? I mean, these would never hold up as, a large randomized study. right? These are smaller studies, and there's been others that, again, tend to be randomized, but they're small and just are not of great quality at the end of the day. But my final answer to you is I defer to my interventional colleagues, but it's always interesting to me how procedurists interprets data versus someone who is more trained in medicine, right, or a medical specialty. And that goes for surgery as well. I mean, and it reflects just the limitations, I think, in the clinical data they have and the ability to generate these type of studies. But at the same time, I was at a meeting recently and they presented a randomized study of transplant versus no transplant for patients with metastatic colon cancer, right? Not an easy study to do, but high-level evidence that is changing the indication for transplant for these patients. UNOS is taking this data and changing organ allocation. That's what we need to expect, I think, as academicians from our colleagues in the field to help guide us. Otherwise, it becomes expert opinion, which is fine. There's expert people. It becomes personal experience, which is of value, but is always shaded by, bias.
So one of the things I want to talk about is the timing of the procedure. So Richard, for you, so if you have a patient that, and you can create whatever clinical scenario that helps like illustrate the point, but if you have a patient that you do want to start an immunotherapy, but you're thinking about bringing in interventional radiology for local regional therapy, what is the timing of that for you that's ideal?
Yeah, so to me, right now, if a patient is a candidate for LRT, they should go to LRT. If they're a candidate for systemic, they should just go to systemic treatment. For the patients who are borderline, Barcelona B, as Julius described, these infiltrative tumors or multifocal bilobar disease, which you're not going to be able to achieve a complete response and maybe even not even a significant PR. And keep in mind, every time a procedure is done, you're taking away a little bit of liver, right? No matter how precise you are, how localized you are to the vessels, there's still a hit to the liver function. And that increases with the size of the tumor or the area that's treated. So for those patients, I tend to say we should start with systemic treatment. Objective response rates now with atezo-bev and others are 30% or higher. The clinical benefit rate, and that's by RECIST, not modified RECIST. Modified RECIST, it's even higher. And keep in mind, when we quote that literature, that's an objective response, which is, as you know, by RECIST, a decrease of 30% or higher. There's many patients who achieve 20% response, 25%, and that's shrinkage, right? And the disease control rate is 70-80%. So I really don't see any problem in going with medical treatment up front. And I think it's probably more data-driven, keeping in mind in all the large phase 3 studies, there's about 15 to 20% of patients who are intermediate, right? And who are those intermediate patients that go on a medical therapeutic study? Well, they're either ones who present with intermediate disease, but aren't good candidates for TACE or LRT, as we discussed what those might look like, or they had TACE and were refractory and progressed, but didn't progress to the point that they have vascular invasion or extrahepatic spread. So there's very strong data. We see outcomes are always better with medical treatment in the Bs than in the advanced Cs, right? It's prognostic. The response rates are higher. The survival and PFS are higher in those patients as well. And just to loop this into my historical perspective, before we had any systemic treatment, interventional radiology filled a void, right? Because from the wide adoption of TACE in the late 90s to early 2000s until 2008, we had no medical treatments that were shown to improve outcomes. So TACE at the time expanded to fill that void. Vascular invasion, large tumors, maybe even some extrahepatic spread, treat the liver. And then in 2008, we had the development of sorafenib, improved survival versus placebo, objective response rates not very high, not a cure, side effects, level 1 evidence, but still there was skepticism about its role because it didn't induce responses, and the survival benefit was perceived to be marginal, but by the hazard ratio, an over 30% decrease in the risk of death with the drug. And so it was hard to push back on IR to say you shouldn't treat these VP1 lesions or vascular invasion or big tumors. And so TACE was done beyond progression. And I think that needs to stop. Right now we have very active regimens, especially with the immunotherapy doublets. And to your point about what should go first, unless it's a slam dunk LRT case, I think they should get systemic treatment first. And again, you can always come back. They have a great response. You want to consolidate with something, you can always have that discussion.
Well, so actually, the question, like you've answered the question, like what comes first, but if you are thinking about a combination of immunotherapy with local regional therapy as like an adjunct, like as these two the theory being that they work synergistically, do you have an opinion on like the timing of that? Or actually you can even speak to like whether you think that is actually a synergistic effect that really exists or not.
Well, I think until we had the studies that came out last year, there wasn't a lot of data to support that approach, right? I mean, we always hypothesize that things that are ablative or inducing tumor injury will induce the abscopal effect or synergize with local regional approaches, though, that is mostly science more than clinical data. Excellent work from Tim Gretton and Brad Wood at the NCI and looking at immunomodulation. But in clinical practice, that really was not, it was really, are you an LRT candidate? Do it. Let's image you. Okay, maybe a month later you're progressing. Then sure, I'll start it then. But, outside of a reason to expose people to toxicity and cost and coming to the clinic, I waited for progression. Now, all of that has changed, I think. And again, we're waiting for regulatory approval. And, this is a good bridge into the next discussion, I think. I don't want to steal your thunder as moderator. But, now with phase 3 studies of medical treatment plus TACE versus TACE alone, I think we have more support for this approach.
Okay. Julius, you're kind of nodding your head a little bit. Would you like to weigh in and like kind of what your practice looks like? And by the way, Richard, I love it when the guests steal my thunder. It only makes it easier. It only makes it easier.
I can see you setting it up. I can see the trajectory.
Okay, good. All right, shoot, Julius.
I would wholeheartedly agree. I think I think HCC care is a team sport, and I think that it needs to be data driven. And in all honesty, I mean, what's going on in our specialty, it gives me a lot of pause and actually headache. And I think we need to be data driven, and we must not rely on just sort of like level 3B opinion and expert opinion evidence, or worse, evidence that is based on conflict of interest or the billing codes that are available to us, right? I think high-level data is extremely important. And as of now, I mean, last year really gives us, for the first time in a long time for IR, high-level data in support of TACE with immunotherapy, something really new, something that we can and need to investigate more, particularly the sequencing of the combination. But I'm enthused because I think that, using both instruments that are available for us to, induce complete response and think of cure, I think is really important. And I think we as interventional radiologists really ought to think about the patients in terms of survival and in terms of actually tumor shrinkage, as we said, although I'm a big fan of mRECIST for studies. I think, and we need to think about the endpoint of median overall survival rather than a lot of other things. Although I know a lot of people in our community will say this is an imperfect endpoint, and progression-free survival and time to progression tumor response are good surrogates. But, being young in the field overall and having another probably hopefully 25 to 30 years of career ahead of me, I'm just thinking how to set myself up for long-term success. And I believe that is through, as Rich says, high-level data and relying on it consistently. So
in your practice, Julius, if I'm curious, like how it does work, like are your medical oncologists interested in combination, like they bring you in specifically because they're like, okay. And so I was curious, like when do you end up treating these patients, when they're on immunotherapy, when they're on a pause, or?
So TACE works. I mean, there are several patients where we're confident that we can achieve a complete response with a TACE, or we see a complete response, and there's sometimes just no reason to really expose the patients to, an additional therapy at this point. Also, I always think about this as kind of a little bit wasting my ammo before they progress or we'll need it down the road, right? And secondly, I think that when we think that a TACE may provide a partial response or good complete response, but the AFP is not ideal, or there is some other small extrahepatic disease, so there I think we combine a lot. And I'm very grateful for having courageous medical oncologists here at Yale who are willing to go for the combination therapies. And sometimes, when there is an indication to start with immunotherapy, then this is started, and then there is, a lesion that did not respond paradoxically as compared to other lesions in the liver, and it needs touching up, right? And then we bring TACE back in. But it's no longer just one versus the other. It's a lot of, really combinations in individual scenarios. But, we're more and more trying to, by consensus, agree upon the combinations when they're needed.
So, Richard, this was a scenario that I actually wanted to specifically talk about. In your practice, how often is it that you'll make a referral to IR when you have a patient that's on immunotherapy, 10 lesions, whatever, 9 of the 10 are responding great, but then you have one lesion that's either growing or not responding at all? Like, how do you think about that scenario?
It's not such an uncommon scenario. And whether it's all in the liver or even, they develop an oligometastatic lesion in the adrenal or the lung. This is more common in patients who have been on for a long time, right? They've had some response, some tumor control, and then they have perhaps escape of one lesion, or they develop a portal vein thrombosis, in which case I've engaged the radiation oncologist. But I have referred back to IR because, there's a data gap there now in second-line systemic treatment, right? We have a lot of drugs available, all the drugs that we had before IO, right? Lenvatinib, sorafenib, Rego, Rafenib, cabozantinib, ramucirumab, a lot of drugs available, but how well they work after frontline IO, we don't know. The biggest improvement in the modern age of taking care of people with this disease is from immunotherapy. So if patients are tolerating it, and also compared to all those drugs I just mentioned outside of ramucirumab, they're not so well tolerated, right? They have side effects that we don't see with IO. Hand-foot skin syndrome, GI toxicity, anorexia. So if a patient's doing really well on IO-based cocktail and their tumor is very well controlled, but they have one lesion that, for lack of a better word, is escaping, I would offer them some procedure with IR at least one time. Give them a chance, because I think that growth of that lesion is either escape or it's just a precursor to more progression that's going to happen in due course. So I don't think there's a role for, picking off 5 or 6 lesions, but, if there's one lesion that escapes, and it also depends on that disease-free interval, right? So you have that lesion treated, but it's different for a lesion that pops up in 2 months versus one that pops up a year later, right? I'm not going to rush and change their systemic treatment. If I would probably send them back to IR.
Julius, anything to add on that, or that mirrors kind of like what your practice is looking like?
Mirrors very much, I think, a state-of-the-art multidisciplinary practice. And we see very similar things here. Yeah, I would agree with Rich.
So we mentioned a lot of studies, but any other helpful studies that we haven't mentioned that you think that if you are someone who's in this space, Julius, from your perspective, what's the data that like up-and-coming interventional radiologists need to familiarize themselves with to give them the armamentarium to like treat HCC in the data-driven way?
Well, I mean, I think it's really important to know the 2 studies that came out last year, the Emerald-1, as well as, the LEAP-012 study. Those are truly game-changing. And it's not only important to know of these studies, it's really important to look at the subgroups that have been treated, be really familiar with the tables and, how different patient subtypes responded. It's really important to differentiate between viral hepatitis C and B patients versus mast cell D patients, because they have different responses. So one needs to not only take them for granted as a whole in a holistic fashion, one needs to be really familiar with the detail. But one also needs to know that a lot of studies are currently underway in the field that will result very soon. I mean, the Emerald 3, Emerald Y90, other studies that are going to be coming out and presenting us with a lot of data that's yet to come. So I love to serve clinicaltrials.gov. I sometimes just go and check it out, what's out there and who is doing new studies and what are the most recent additional protocols and what are they looking at. So I think aside from reading literature that exists and reading really good, high quality, high level reviews and meta-analyses, I think it's important to just know what's out there to practice in a state-of-the-art fashion.
Richard, same question to you, but the bend I'd like to take with it is, what are the studies that you wish that more interventional radiologists were familiar with that maybe outside of IR or that you think are kind of cornerstone resources, like just understanding HCC?
Yeah, I mean, they need to be familiar with the at least 3 or 4 large studies that have changed practice in advanced liver cancer, because it's important to understand who the patients are that are enrolled in those studies and how they behave, not only in the treatment group, but also in the control group. And I would start even with an appreciation of lenvatinib from the REFLECT study, which looked at len versus sorafenib and demonstrated how len differentiates itself as a TKI in that population, was the standard of care until another study they need to be aware of, the IMbrave 150 study, which was the atezolizumab plus bevacizumab versus sorafenib study, the first time we improved survival versus sorafenib, and really long, durable objective response rates of 30%. And then also looking at the subgroups in these studies of the Bs versus the Cs, because the Bs are in your shop as IR for sure. And then since IMbrave 150, we have the Himalaya study, which is durvalumab and the CTLA-4 antibody tremelimumab. That study was positive. And recently we saw at ASCO the Checkmate 9DW, which is ipilimumab and nivolumab. This is after they take a course in modern oncology language, but ipilimumab and nivolumab, which is again a CTLA-4 and PD-1 combination, which has a very high response rate, 36%, and that was compared to lenvatinib, mostly lenvatinib or sorafenib. And then there's another study which is not yet approved in the US, though we're awaiting data or a decision by the FDA in the next few weeks, the CARES 301 study. And this was a mostly Chinese cohort, which is why we'll see how the FDA decides, but it was rivasirinib or apatinib, a very potent VEGF receptor TKI, in combination with camrelizumab, which is another PD-1 inhibitor. And this was, again, a very positive study. And there's nuance. Some of these studies include patients with main portal vein invasion. Some do not. Some have improvements in PFS. Some do not. And I mean, they need to be aware of the data, but I think if someone's interested in academic medicine, they need to understand clinical trial design in liver cancer and endpoints, and all this becomes very important.
And maybe I can add also one more thing. I think for interventional radiologists, and particularly in debates and when you make decisions about, what instrument to use or what type of therapy to use, just look also at the control arms, because, sometimes look at the Emerald 1 and LIPA 1-2 control arms with TACE alone. And if you look at this, I mean, this is prospective data right there collected historically. We have dramatically improved the way we do TACE. In the older studies, we look at median overall survival intermediate stage of like 20 months, 18 to 20 months. Now, some of the control arms are bringing us up to 35, 36, sometimes even close to 40 months. And I think that this data is very important to know. The protocols, how it's done is important to know. And study design is critically important. I can only strongly second what Rich said. I mean, what is the endpoint in this study? Is this progression-free survival? Is this median overall survival? What is going to be guideline changing? And how can you apply it to your own cohort that you're seeing? And again, I mean, just look at this small print in the tables.
Richard, I would be remiss if I didn't ask you this question. You've been very kind and judicious with sometimes your answers and your commentary on interventional radiologists. What drives you crazy about interventional radiology within the HCC space? What's something like that gets you pulling your hair out?
And I alluded this before, what's termed a positive data, what's supportive data, what's talked about from the microphone or from the podium as high-level evidence, right? You look at Cervinib and the SARA study, right? These were Y90 with systemic treatment versus sorafenib, right? Sorafenib versus Y90 and sorafenib. And they were negative studies, right? But somehow there's an excuse. They weren't done right. they didn't get the right population, the centers weren't good. Okay, great. Then do it the right way, right? I give them credit for trying, right? For doing the study, but you did the study, you got the answer, and it's done. Similarly, as I said before, if we had a drug with those results, they're gone. Done. Right? But somehow it's the limitations of the evidence or the studies that convince people somehow that things are okay, what we do, or, generating that high level evidence is not there. The drive to do it or the commitment to do it is probably the most frustrating thing.
Fair. Although, don't worry, we just edit out all the criticism from medical oncology anyway.
Well, look, this will be another discussion for you all, but histotripsy, right? That's the newest kid on the block and it's just exploding. And where's the data?
Sure, absolutely. We talked about it a little bit in BackTable Tumor Board, but certainly plenty more to discuss in that. Absolutely. One of the main questions I had, so when you approach a CTACE procedure, so you're going to do TACE, do you approach it similarly to how you would map a Y90 in that you start broad, maybe you would do a cone beam, and you're trying to get every piece of that tumor, with as much rigor as you would radioembolization?
Yeah, no, absolutely. I mean, I would think that being super selective in a TACE and getting all the branches is basically the key to success. I think that the experts in Japan and South Korea, from whom I learned a lot actually over the years in conversation and also during visits, they're absolute masters in super selective TACE. I mean, they use very, very small microcatheters, get out real far, make sure they cover all of the tumor and get it all done in one shot. They're able to treat recurrences is sub-centimeter size in super selective fashion and preserve a lot of the liver parenchyma. So I think that's absolutely the key to a successful chemoembolization.
Does it matter how much of the drug you get in, or can you talk a little bit about how much embolic you have and then some of the doses of your chemo? And then,
so for conventional chemoembolization, there is a very well-established standard protocol that is actually published by a bunch of really famous folks. Mike Solon, Thierry Debert published a standardized paper long time ago on the standardization of conventional chemoembolization, and usually it entails a 2-to-1 emulsion, very important. This is a water and oil emulsion where you have just small sort of aqueous phase droplets that contain the drug in contrast, emulsified in oil. It is very important that the emulsion is maintained at all times because otherwise if it's de-emulsifies, then the drug flies off and just goes systemic and doesn't get retained in the tumor. And so when you create this emulsion, my rule is to be very specific. You have the 10 cc vial of Lipiodol, you draw that up, then you draw up your drug in sterile water that is, in a small volume, as small as possible. Ideally, in my institution, we work with a pharmacy to create a 2 cc formulation of doxorubicin in sterile water. And then we add a little bit of contrast to it to make sure that it's roughly 2-to-1 between the Lipiodol and the watery phase. And then you emulsify this in a standardized fashion between the two syringes. You iterate it until you have this really nice sort of lava from going from this lava lamp appearance to this nice bright orange color, the emulsified doxorubicin. And you iterate it, and it's very important to make sure that you use syringes that are resistant to the effects of Lipiodol. Sometimes it eats through certain type of syringes. In Europe, there is the Victorio system that prevents that. It's not approved in the United States, but you can do it with regular medallions. As you prepare to embolize, you really dial down your volume to, from 20 and 10 towards a 3 cc medallion and a 1 cc medallion, and iterate and keep it all in emulsion at all times. And then you inject it depending on the tumor, and then the flow in the vessel, you can inject it relatively fast, or you have to slow down. But it's really, to me, it's key importance to keep the emulsion, to keep the combination emulsified at all times.
And as far as how much of the drug you get in, I'm setting up kind of a straw man, but are you trying to get every cc of Lipiodol or every cc of your mixture in?
Well, that strongly depends on the vascularity of the tumor, but as well as on the size of the tumor, right? I mean, a small tumor will take far less than a large tumor. And obviously, it was very well defined and explained that what you want to see in an ideal case scenario is sort of the portal venous drainer, is where the Lopidol, steps out of the actual lesion, and you can see give it a nice corona around the tumor and the surrounding small portal venules. Then you know that you really achieved the right embolization endpoint, but also not to push too much to push it all out into the portal vein. So you kind of need to understand your embolization endpoint, and I think that's where the critical part is about being good at a C-TACE, and where it's maybe somewhat more difficult and less reproducible than doing a Y90, because it really is strongly user dependent. And if you don't know these things, and if you don't have a good feel for an individual tumor and don't know when to stop or stop too early, then you may not achieve a really good complete response in this. And so I think it takes a lot of practice, but once you get there, you can achieve really good standardized coverage. But I would not say that I have a cutoff of specific amount of drug. I think it's more so an imaging based on Lopidol as an imaging biomarker, where I try to establish an endpoint and see a complete tumor coverage. I think for me, cone beam CT is an absolutely essential part of the procedure. I opt first as a standard for all my TACEs. I obtain a dry cone beam, no contrast, no nothing, just to see sort of like a negative image of the liver. Then once I approach the liver itself, depending on how easy I think it's going to be to select the tumor and to see its supply, I do a dual phase cone beam CT just to see the supply of the tumor, and then I thread myself closer, and when I'm at target, I inject with contrast to see what I'm actually covering, and do sometimes a single phase delayed just to see where the tumor stain goes, where my Lopidol is going to go, to make sure while I cover the target, I also don't cover too much of non-target and have feeders outside of the liver. And once I'm there, I start embolizing. It's a living and breathing thing, right? There is flow that is involved. There is perfusion from other branches, and sometimes we use balloon enhanced TACE. You also have to learn how to do that, and what tumors might actually do fairly well. Some may not go that well with it. But I think, if I have to make a rule of thumb, so always make sure you have a 2-to-1 emulsion. Always make sure you have a cone beam CT to map out your target, and always make sure to keep the emulsion emulsified, right, so that it doesn't separate too early. And then watch the angiographic endpoint of portal venous drainer if you have that.
Okay. The last question I had for you is, you mentioned that sometimes you supplement or follow up with a bland embolic, and what's the size of the bland that you use?
I mean, ideally, in a tumor that is peripheral and where I don't think that anything's going to fly through and on target, I try to use 1 to 300 micron beads. Usually, in a tumor that is in a more risky position, or where I assume that there might be a large tumor bed where the 1 to 3s are just not going to occlude very well, and I need just something more proximal, then I use 300 to 500 beads. They're sometimes safer in critical locations or in parasitic branches. I rarely or almost never use gel foam unless it's to protect the territory, because there's just sufficient data to prove that permanent embolic is going to, just surely achieve a better retention of Lopidol in the tumor.
Okay, well said. All right, so something I'll kind of leave off is final thoughts. Like, it can be either how far we come, things that you're excited about in the future, either upcoming studies, whatever. Julius, where are you at on that?
So I'm just very excited to be in a field that is so rapidly evolving, and has brought a lot of change into the specialty. I think that liver cancer for interventional radiologists is, in my view, and I'm, guilty of being biased, is probably the most interesting intellectual field to deal with, because it just offers you so much reward, because you can achieve complete cure in patients. You can deal with exciting, imaging instruments and image-guided therapies at the same time you interact on a biopathological level and engage in novel therapies, understand cellular mechanisms of tumor response, and have so many evolving new drugs. And I think it's for the first time that this kind of disease that we treat also encounters a lot of interest from industry, from pharmaceutical industry. That means that there's a lot of advocacy, a lot of money, just frankly, coming into the specialty. And I think that's an opportunity for us to ask the right questions, do the right trials, get them funded, and get them done. And I think that's a once-in-a-lifetime opportunity where if we don't lead, we're going to be followers. And I think that it's going to be up to us to generate the high-level data that we need to maintain our membership in the multidisciplinary care team.
Richard, same question. Final thoughts, something you're looking forward to in the HCC space, or either just how far we've come?
Yeah, I mean, I think Emerald 1 and LiPo 1-2 are very significant studies, and should be a backbone for places that don't necessarily have multidisciplinary programs to put them together to build collaboration between IR and medical oncology. I mean, these were very large studies that were very complex to do because of data collection from radiology, from medical oncology, from blood draws, from imaging assessments, and they both met their endpoint. So these type of studies can be done and successfully. And I think it's imperative that we continue to generate this high-level data set to guide practice, right? And I don't think it's an excuse to say it's too expensive, it can't be done, people aren't interested. You need to be committed to research. You need to be committed to getting the answers. These studies will continue to give a lot of data, as Julius alluded to, from the subgroup analyses to understanding the natural history of liver cancer in the modern age, and how, there'll be biomarkers, correlates coming out of these studies, and really optimize how we approach patients. And that should always be based on high level of evidence, as these studies have generated. And again, not every patient, most patients we don't see are going to fit perfectly into any box. There's clinical research and clinical practice, but clinical practice needs to extrapolate, I think, from, high level evidence.
Well said. All right. I think it's a good point to put a pin in it. That wraps things up. We'll see you next time on the BackTable Podcast. Richard, Julius, thanks for coming on.
Thank you. Be well.
Thank you.
All right.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for listening. See you next time.